He's actively involved in thesis supervisions and has been spearheading various research projects. He's also PhD adjunct international faculty. His work has involved early implementation of negative controls in epidemiological studies, the use of cross-context comparisons, sensitivity analysis, unobtrusive data collection methods, and randomized trials in thought to be difficult situations. He pioneered the use of germline genetic variants for investigating modifiable causes of disease, developed several extensions of the basic method, and contributed to its application in many settings. He is an advocate of the pre-specified application of a range of methods with the different structures of potential biases to the same question as a key approach to strengthening causal inference. Beyond his theoretical contributions, Professor Daly has been instrumental in making data more accessible. His leadership in the longitudinal study of parents and children, it is a testament to his commitment to democratizing data accessibility for the greater good of public health. Without further ado, let us warmly welcome Professor George Davies Smith to our class as a professor, as we are not only welcoming him as a professor, we are welcoming him as a mentor and a thought leader. Looking forward to your insights, Professor. Additionally, today's lecture being live streamed via WebEx, and it is our fellow organizations, IOPHs, joining in live. It is a kind request to kindly drop in your questions and any doubts that you have during the course of lecture into the chat box. The floor is yours, sir, and we request you to kindly come here because WebEx is. Thank you, sir.
How are you? Thanks so much. So it's a great pleasure to be here. I was involved in discussions must be 2 decades ago when PHFI was being set up and spent a year in Delhi in 2009, 2010. But the one thing I've noticed is that the atmosphere hasn't got better in the last 12 years. But it's great. It's lovely to be back in Delhi. And I'm going to talk about etiological epidemiology. So when you are doing studies to try and establish causes of disease and advocate for using multiple methods in that regard, rather than to consider just using one study design. So this is an approach called triangulation of evidence. I'm going to start by saying why we need triangulation of evidence, and then briefly go through some of the stages or possibilities with such studies. So when we learn epidemiology, we learn particularly about cohort studies, for example, and that they have advantages in many cases over case control studies, and ecological studies provide weak evidence, etc. There's often a hierarchy of evidence. But I'm going to start by saying, why do we have to consider different approaches rather than just doing what are considered to be the best observational studies you can do. I'm going to go back to give an example. One that had a huge influence on me, so I'm going back to this. These were studies of vitamin E supplement use. So this was taking a supplement of vitamin E daily, and many people in the United States and the US were taking vitamin E supplements. And has anyone here heard of the Nurses' Health Study and the Physicians' Health Study? So these were these two massive cohort studies in the US, and they collected data. They were particularly interested in diet and in reproductive factors in the nurses' study. What they did is they asked people if they used vitamin E supplements, and then they asked many other things. Smoking, obviously, physical activity, body mass index, etc. And later they had blood measures. What they found was that the people who took vitamin E supplements, they had lower risk of heart disease, about 35% lower. So big difference in heart disease risk after they had statistically adjusted for all of the other factors that might influence coronary heart disease that they'd measured. And they also had the health professionals follow-up study, which was male health professionals, and they had the same sort of data on them. And they published two papers back to back in the New England Journal of Medicine in 1993, both studies showing substantially lower risk of coronary heart disease in people taking vitamin E supplements. And this is the lead news story in the New York Times. It knocked Bill Clinton off from the main headline. And the main headline is "Vitamin E greatly reduces risk of heart disease," study suggests. So the headline makes a causal claim. You reduce the risk. This means you're actually having an effect on heart disease. And it was shown in the studies. They showed that just taking vitamin E supplements just for 2 to 4 years, you were getting as lower risk. If you've taken them just for 2 to 4 years, you were already getting this 35% lower risk of coronary heart disease. That's just sort of simply taking a supplement. So you have seen this got very widely publicised, and because of that wide publicity, after the study came out, there was a specifically large specific jump just in taking vitamin E, but also just taking multivitamins that contain vitamin E. And at one stage, 50%, nearly 50% of the US adults were taking supplements that would contain vitamin E. And in the studies themselves, being health professionals, the people in the studies, they responded to this of course. So this is in the Nurses' Health Study, amongst the non-smokers at 50%. We're taking vitamin E. As you'd imagine, there's some confounding a lower proportion of the smokers, but still a very substantial proportion of the smokers were taking vitamin E. And that just increased after the study results came out. And the same happened in the male health professionals, that there's substantial increase. So this had an effect on the participants. And so the trajectory carried on until some large-scale randomized controlled trials were set up, randomizing people to taking vitamin E supplements or taking a placebo. And the randomized controlled trials went for up to 12 years, and there was tens of thousands of people enrolled in randomized controlled trials. And at the end of those trials, the taking vitamin E supplements had absolutely no benefit. So the trials, they were taking vitamin E supplements for a few years, which is, as I showed here, observationally, you were seeing this benefit, this apparent benefit. in that same time period. But the randomized trials are precisely the same thing. So this is just opening the jar, putting the tablet and swallowing it. That's what you're doing. Precisely the same thing in an observational study and in the randomized trials, got completely different answers. And you can say, well, does it really matter if people are taking vitamin E supplements? At least it's not killing them. But there's only a certain repertoire of health protective behaviours people can do. And if you're smoking, you might think, well, I can carry on smoking because I'm taking something which is protecting my heart. So once the results of the trials came out, people stopped taking vitamin E. This is a particularly educated group. Now, that scenario over the subsequent 10 years was repeated again and again. There was beta carotene was very popular, taking beta carotene supplements. And these studies actually showed the same protection, apparent protection for taking beta carotene as they did for vitamin E. But they were only published in an abstract together with the vitamin E results. But the beta carotene findings never got published in the New England Journal of Medicine. In fact, they were never written up as a paper. Because, and people stopped taking beta carotene very soon. And the reason for that is quite simple. Is the randomized trials for beta carotene came out before they published the observational studies. But they found precisely the same thing. And the large-scale beta carotene trials, if anything, had adverse consequences in terms of there was a suggestion of increased risk of lung cancer in people randomized to beta carotene. And the same thing was seen for vitamin C, for folate, for hormone replacement therapy, selenium in prostate cancer. In all these cases, these well-done observational studies got dramatically the wrong answer, and these were impactful answers because people changed their behaviours in response to them. So the point there is that we all know that we should replicate studies, but replication, if you're replicating the study in basically a similar sample, so if you a high-income country, if you did the study in the UK, the same things were seen in the UK observationally in the British Regional Heart Study and other studies. And what it does show is that even when you're comparing directly the same things, you get very different answers. And so it seems to me that this had a huge effect on what I did, because it seemed just carrying on doing these studies wasn't the way forward, because they could clearly get completely misleading answers, and how could you know if any of the answers were sensible? So for the variety of evidence thesis suggests that the volume of data generated from similarly biased sources stops having a value. Once you've replicated a finding a couple of times, then it's no good carrying on replicating the findings in the same sorts of study sample. It doesn't add any value. The beta carotene observational associations replicated everywhere. This is with cardiovascular mortality, and this is showing in the trials, if anything, adverse outcomes of being randomized to beta carotene. So the replication ceases to gain value. And this is just a standard finding. It's within the social science setting, but this is a study where they gave 73 research teams the same data set for testing a particular hypothesis in social science, and then they were sent away to them as teams to produce reports with the same data. And what you found was about 60% came up with findings which the findings aligned with zero. But 17% got positive findings and 25% got negative, got statistically significant. Not that one should carry on using that term, but that's a different story. But but these are going to be with the same data set by the analytical choices you make, how you analyze the data, you can get answers pointing in just opposite directions. So what's required is a variety of evidence which involves different methods and domains of data, rather than replicating studies in the same setting. And you can reason that different study designs the findings for one design would be independent of what the other study finds. So for an observational study in a randomized controlled trial, the observational study is distorted by confounding and selection biases, etc. You don't get confounding if you have a properly done randomized controlled trial. There has to be some form of informative dropout, non-compliance, which you don't realise that some side effect of the actual tablet is stopping people taking it or something to distort the finding. Those biases are completely different. In the randomised trial, it's not because the people who aren't taking vitamin E smoke more, and you just can't measure smoking very well. There's always residual confounding. The biases will be independent. So if the two study designs both point in the same way, it's not that randomised trials have got the wrong answers in quite a few situations. It's not that randomised trials will always give you the right answer. But if the different methods line up, then that greatly strengthens your influence. And the summative mechanisms linking exposures and outcomes adds to the evidence, and you can actually have a sort of chain of causation, how the exposure actually influences the outcome. And you don't actually need to quantify it, but that's a different story in some settings. So what are these different these varieties of evidence beyond conventional observational studies? And the issue with conventional observational studies is that they're able to control the confoundings, but you have to say there's no unmeasured confounding and there's no measurement error in the confounders. And epidemiological data always has some measurement error. You can't measure everything perfectly, and you can never know that you've measured all of the confounding factors. And there are just so many examples of statistically very robust findings which simply turn out to be incorrect. So rather than just carry on replicating your observations in the same sorts of contexts, what one would need to do would be to think about in what context would the confounding be different. So I used to study called the Avon Longitudinal Study of Parents and Children in Bristol, where I come from. And in the Avon Longitudinal Study of Parents and Children, breastfeeding in infancy is associated with more favourable outcomes for everything. The children have been breastfed, have lower risk infections, lower rates of obesity, lower blood pressure, greater respiratory function, better cognition. They also got larger Christmas presents, because in Houseback we actually looked at what they got for Christmas. Because of course the kids who were breastfed in the early 1990s came from families which had more financial wherewithal, higher education, etc. So breastfeeding predicted everything, including the condition of the house and outcomes which just obviously can't be influenced by breastfeeding. But Richard Martin, who was with us, did these meta-analyses of all these studies, and in high-income countries, they always showed the same thing. They all showed that breastfeeding was associated with lower obesity, lower blood pressure, higher cognition, etc. So it's not worth carrying on replicating. But the state of Victoria had set up a birth government in Pelotas in 1982, and this is Mike Pelotas, the seals, and we've worked extensively with them. And the strength of this is that in Pelotas, the confounding is just different. So in Pelotas in 1982, breastfeeding was not associated with the educational level of the parents, the financial wherewithal of the parents, health behaviours of the parents. It wasn't patterned in that way. And we could, it's quite easy to see, this is breastfeeding at 3 months in Columbus and Elsbeth, where in Elsbeth it's very strongly, more than doubling across the quintiles of income, and similarly percent ever breastfed. So very different confounding structures, which shows the same thing in the two studies. And in Elsbeth, as I said, we know it was seen that breastfeeding was associated with lower blood pressure and lower levels of obesity, lower body mass index, and higher cognitive function. In Pilates, where there was weak social patterning, the confounding wasn't in the same direction. There was no meaningful association with blood pressure. The association with BMI was in the opposite direction of anything. But the association with better cognitive function was seen. And then there was a cohorts collaboration. These were cohorts in low and middle income countries, including the New Delhi birth cohort was included in this, where again breastfeeding 40 years ago, whatever it was set up, wasn't socially patterned. And if you put all of those low and middle income countries consulted together, you found no official effect, with blood pressure or BMI. But the cognition effect was seen in only a few of the, only a couple of those cohorts that actually measured it. And there's one randomized controlled trial of breastfeeding, which is a cluster randomized trial in Belarus, which had very low breastfeeding rates, and hospitals, 32 hospitals were randomized for the promotion of breastfeeding or not, and they created a big difference in breastfeeding. And Richard Martin was involved in following up with randomized controlled trial, and with about 16,000 children, you could show by randomization that there was no effect on blood pressure or BMI, but there was an effect, a found effect on cognitive ability. So there you have a situation where you deliberately go and take a different context, and when the confounding structure will be different. And that's, one study in a different context is more valuable than 40 more studies in the same context, because you've got your first set of results. And context doesn't mean, it doesn't have to be geographical, it could be like temporal. When things have changed over time, you can go back and look at cohorts that were done in Britain in the 1940s when breastfeeding wasn't socially patterned. One which is, I just enjoy this one, is that eating fried food in the US and the UK, higher income countries, is associated with higher mortality, and fried food is just bad. But wonderfully, in the big study that was set up on smoking by Hammond and Vaughan in the 1950s, and in the 1950s, fried food, which was steak, fried food was actually would be fried meat would be expensive, and so it was just certainly wasn't negatively socially patterned. It was probably positively socially patterned. And this is one of my favourite findings. You have to go and get the whole report and look in the appendix tables. So this is really one of my favourite findings. This is fried food from none to 15 plus times a week. So that's at least breakfast and plus one lunch. You're having fried food. And amongst the smokers, smoking is bad for you. Don't smoke anymore. Smoking is definitely bad for you, whatever the context. But there's just all in mortality, right? You just can't eat too much probably. But no one looks at these findings, and the results of these papers that appear are less striking and less robust. And of course, this is massive confounding in the same way as this confounding vitamin E supplement use. Other factors, ultra-processed foods is, of course, the new thing which is bad for you. So that brings me on to negative controls. So negative controls would be either an outcome which couldn't plausibly be caused by your exposure, or an exposure which couldn't plausibly influence your outcome, but that would be patterned socially and by behavioural factors and by other important confounding factors, would be patterned in the same way as the outcome or the exposure that you are interested in. And I think my first negative control, as I called that then, was in the paper in the Lancet in 1992. And the giveaway is the title of the paper was Smoking as Independent Risk Factor for Suicide, illustration of an artifact from observational epidemiology, it was called. And many papers have come out showing that observation of smoking is related strongly to increased rates of suicide. But one can think of very obvious confounders of that association, but also you can think of reverse causality. That if you're depressed, people who are depressed are going to find it harder to give up smoking, for example, and you can medicate with nicotine. So I thought, well, what's a negative control which is patterned in the same way as suicide or in similar ways, but which couldn't plausibly be caused by smoking? And this being the US, the one I thought of was just being murdered. Sure enough, smoking was associated with twice the heavy smokers have used the word on homicides to divide into 5 groups. But the heavier smokers would have twice the rate risk of being murdered. Now that is not a plausible. This is not plausible. The only thing is you could think of that would make it plausible is the provisional wing of the health promotion agencies that started shooting smokers to stop them smoking, and that's like the only way that being murdered could be related to smoking. I mentioned the ultra-processed food because diet, nutritional epidemiology and chronic diseases has had a terrible history in terms of application, and the results being supported by randomized trials, for example. And in India, so you get a lot of publicity on ultra-processed food. These are the highly processed foods. In the UK and the US, they are the new poison, and they relate to our digestive head and neck cancers, but they relate to everything because they are so patterned by social position, by health behaviours. So this is coming out tomorrow, and we looked at the association with head and neck cancer. Then we looked at dying through accidental violent deaths, and we've got the direction is a similar effect in a similar direction. Now, this doesn't mean that the findings are wrong, but it does mean that you would want to be more cautious about them, and you think that you would need more evidence than simply replicated findings in the same context. And I'll just give one negative control exposure. But this is just to try and get over the general principle that when you're studying one particular outcome, it's just important to look at different outcomes, including ones that couldn't be caused by your exposure, and do the analyses in exactly the same way, adjust for the similar factors. Do the same analytical strategy and see the findings are the same or similar for the negative control. We do a lot of work on antenatal exposures like birth control, and an obvious negative control for mothers smoking during pregnancy is if the fathers have smoked during pregnancy. Now, if you're looking at intrauterine influences of smoking on health outcomes, clearly paternal smoking can't have anything like the effect of active smoking. I mean, it's like a tenth of the maximum amount if you sit next to someone who's smoking and blow breathing out of your face is about a tenth of a cigarette a day equivalent or whatever you measure. So you can look at the father smoking, and for something which the evidence of causality is strong, which is birth weight as well, you see that for the mother's smoking, the adjustment for the factors in the death smoking has no effect. But for the father's smoking, there's no residual association with birth weight. So that's what something which is causal looks like. But smoking amongst mothers has been related to everything bad as well, rather like the inverse of breastfeeding. It's been related to obesity in children, attention deficit, and etc. etc. Those consequences. And if you look at obesity, body mass index, the obesity rates look the same. Then the paternal smoking as an association, which is relatively similar to the maternal smoking, which casts some doubt on the causality of that. So you can use negative controls a good way of interrogating the data. Within SIDSHIP studies, if you think that confounding might be by factors shared within a family, especially if you're doing studies in children, for example, comparing SIDSHIPs can be done. Regression discontinuity design would be one of the family of studies where you are using some perturbation, some external perturbation which changes exposure rates, but shouldn't be related to confounders. One that I like is age and coronarity bypass grafting, because the guidelines in the US, for example, you have a sort of 80. If someone comes in and they're below 80, you have a lower threshold for going for stenting. If they come in and they're over 80, you're less likely to get stented, and they are definitely less likely to get stented. So this is the adjusted percentage of patients who underwent inpatient cabins, so not stented, getting a coronary bypass graft. And if you look at so this is the people who they came 2 weeks before their birthday and 2 weeks after their birthday, 77, 78, 79. But then at 80, this is a big difference. If you're 79 and 11 and a half months, you're more likely to get your challenge if you were 80 plus half a month. So that's getting a cabbage. So how does that affect your outcome? So that is the mortality. So one of you are only approaching 80, but the thing is, what that shows is that suggests that actually getting the coronary bypass graft is good for you. It's unlikely that there's something magical about 80 that suddenly makes it bad, and then it's less as you get older. So the lesson there is, if you ever get admitted, just lie about your age. So but that's just telling you the principle of getting something like something changes on a certain day. It needs to be used quite widely. And Pat, who watched the Mendelian randomization video? I'm going to go on it. So I had a video to show, which a 2-minute video to explain Mendelian randomization, which is impossible to do outside of the 2-minute video. So I'll try to get everyone to watch it, because then you want to think about IP addresses. And then I clicked up more shows, and eventually I will earn a penny for 50,000 views. So everyone go away and watch it afterwards. Then you'll know about Mendelian randomization. That is using a genetic variant which influences a phenotype like alcohol drinking, or smoking, or your cholesterol level, or beta carotene circulating level, or whatever, and using that as an indicator of the actual exposure, because the genetic variants, especially if you look within SIDSHIPs, which we now is the gold standard, and after we look between two siblings, where your Mendel's laws means that your genetic variants have truly been randomized to you from your parents. So it's like a randomized perturbation of the phenotype, and then you can find out what the phenotype does. That's the video. So the answer is just search for Mendelian randomization in 2 minutes and it comes up. You can also use genetics to estimate confounding, and this will be not only being able to show, not being able to show the video. This might be a little difficult. Yeah, and basically, we know that there's measurement error in confounders, and you might be missing confounders, etc. But Mendelian randomization being an instrumental variable approach, instrumental variables adjust for measurement error. So you actually get the result of finding as though it has been adjusted for a measurement error. And this was a study on levels of small HDL, or high density lipoprotein cholesterol, and its influence on the risk of sepsis. There is evidence in the UK, there's some UK biobank helping million people which are more in the UK. And there's other studies have done, the fact there's really well strong association between the small high density lipoprotein level and this lower adverse outcomes, in this case sepsis death, but it's saying for the severe sepsis. And there was a very considerable interest in this. Now, you could actually do Mendelian randomization for this because there are genetic variants that relate to having higher levels of the small HDL, and the Mendelian randomization didn't provide very strong evidence of causality. Not direct from one of the 3 comparisons. So that's. Oh, sorry. Yeah, sorry. That's terrible. I've got sorry. So that's using Mendelian randomization to get an estimate of the phenotype. You're using the genes to get an estimate of the effect of the phenotype. In this case, it's small HDL on the outcome. And what we looked at then was we know that interleukin 6, IL-6 activity has a very strong effect on sepsis mortality. And so we looked at to see how IL-6 influenced the small dense HDL. We first looked at how it was for CRP to show that it was working. So we're looking to see IL-6 here onto the HDL particle count, and what we showed is that the IL-6 does indeed lower the HDL. So the IL-6 appears to be a confounder because it's very strongly related with sepsis mortality. So no, you can't in these studies have measured IL-6, but you can use the genetic variant to get evidence on whether there is confounding. So it can be so it's only been sort of recently been people looking at this, but it can be a very powerful way of actually finding out what confounding has existed in a study when there is genetic data. You can use, there are non-genetic instrumental variables. So an instrumental variable is something which influences your exposure, but doesn't have a plausible way of influencing the outcome except through the exposure. And so for smoking, for example, people have used the changes in smoking taxation rates between US states, and they change quite frequently. That one state will be putting more tax on cigarettes than another, and they influence smoking because it is quite marginal. It's influenced by such changes, and then you can use that to estimate the effect of smoking on outcomes like birth weight. It's been used to show that birth weight is indeed lowered by smoking. So there's huge numbers, there's lots of potential non-genetic IVs. the issue with intermediate variables is to know that they really don't plausibly influence the outcome except through the exposure that you're interested in. Randomization in the trial can be thought of as an instrument, but of course, you're randomizing people. But it's an instrument that you believe. But obviously, that's a lot of incredibly expensive and can't be done for many situations. So there's increasing interest in IVs, in simple variables, in estimating observational effects, and randomized controlled trials, of course, give strong evidence. And maternal smoking and birth weight of offspring is one situation where there is evidence from a series of sort of study designs that I've discussed. All of them point in the same direction. I showed the negative control study analysis, but all point to the fact that maternal smoking during pregnancy does indeed lower birth weight. And depending on the issue you're studying, there might be some. There's many other. I've only talked about a few of these different ways of obtaining data and different ways of interrogating causal effects. So you choose the studies that can be used depending on your question. So in the situation of smoking and birth weight of offspring, the children of monozygotic twins is very powerful. So if you have a monozygotic twin pair of women who've had kids, and one smokes and one doesn't, then of course you're matching for everything in childhood. You're matching for germline genetics, etc. So you've got to, this is just to sort of highlight. You choose the studies that will be informative for the situation you're looking at. This is just talking about sort of formal ways of actually showing that biases would be unrelated, but no one will be getting lunch if I carry on talking about it. So many times you actually get estimates. You can get estimates from these methods, but not all of the methods will actually give you an estimate of the causal effect. They will just help you in a qualitative way, really weigh up the evidence for and against the hypothesis. But when you can estimate an effect, as you can with several of the methods, you've obviously got to define what's the estimand, and the estimand will be the target intervention that you are trying to estimate. So the estimand is the actual description of what you are trying to estimate, or what you can estimate. And the point is that different methods will have different estimands. So let's take HDL cholesterol and coronary heart disease. So HDL cholesterol used to be called good cholesterol. It was believed for years that it was protective. Literally billions of dollars were spent on randomized controlled trials elevating HDL cholesterol by a variety of methods, and it had no benefit. So whatever way you elevate HDL cholesterol, that will be benefit. The sad aspect of that is that alcohol increases HDL cholesterol, and so that was always thought why it appeared that alcohol was protective against coronary heart disease. The bad news is that alcohol isn't protective against coronary heart disease, and Mendelian randomization, which is very powerful in setting alcohol, demonstrates there's no protective effect, and HDL isn't protective anyway. So, but why I talk about HDL is just to give an example of where you know that your estimates are actually targeting a different underlying hypothetical thing that you are estimating. So in drug trials, for example, of a drug that actually, I'm now looking actually non-HDL. This is actually lowering bad cholesterol. Sorry, I moved on to bad cholesterol. I'll take that slide. So this is lowering LDL cholesterol or non-HDL cholesterol. So this is like statin trials, with a statin, and the trials go on for 5 years. And you lower what the group is randomized. The statins have lower cholesterol for 5 years compared to the control group, And you get, and these are the effects that you get in the different levels of lowering of this in the different dose trials, and then with four different types of cholesterol-lowering drugs. For each of these cholesterol-lowering drugs, you can also do Mendelian randomization using the genetic variant that relates to the bad cholesterol, and then you can estimate an effect of the difference in cholesterol generated by the genetic variants. But you get the genetic variants at conception, when you're conceived, and at birth in ALSPAT you can already show differences in cholesterol levels in cord blood and at age 2 and 4 through the genetic variants. So with the Mendelian randomization, you're estimating the lifetime difference. You're estimating a long-term difference in cholesterol, not 5 years difference. So so what you see where you get a much smaller, you get about 35 to 40% of the effect in 5 years. That is generated by a lifetime difference in cholesterol. So that's actually useful information. So that, those differences are pretty useful because you can get 40% of the potential lifetime benefit. So it's never too late to start taking a statin if your LDL cholesterol is high, and you might not want to start taking it at birth if you get most of the effect if you start taking it at 30, for example, or 40. But that's just to get over the point that it wouldn't make any sense to meta-analyze these findings because they have a different estimate. And I'll go on to examples of when you actually can combine these different approaches. So this is combining two approaches. I mentioned Mendelian randomization, and I've also mentioned regression discontinuity analysis. So in the UK, for the 500,000 people in UK Biobank, we have quite a good regression discontinuity because they changed the law on when you could leave school. So it was changed 2 years before I was able to change. You could leave at 15. When I went to school, you could leave at 15, but when I was 13, they stopped you being able to leave at 15. And so you had to stay to 16. So that law made a difference to the amount of time people spent in education. It increased it by about 4 months on average because a lot of people left at 16. They used to leave at 15 and had to leave at 16. They got a year extra education, and some of those found it wasn't too awful and stayed on. You can do with Mendelian randomization. There are a series of genetic variants that relate to having more years of schooling. How these work is there's obviously not some specific variants. Schooling is a large number of just sort of anonymous variants, and so you have a whole series of sensitivity analyses and Mendelian randomization to try and take into account possible biases and biases. But what we've shown was that both the regression discontinuity and the MR got larger estimates of beneficial effects of school leaving. And as I mentioned, incidental variables, I think regression discontinuity is a form to be correct for measurement error. So you would expect to see larger effect estimates. But the fact that they sort of agree pretty well is quite, when one is using genetic variants and one is using a change in the law. I must admit I was surprised when we saw these results because my experience at school was that I didn't think that changing that law could be good for anyone, because I thought it just meant that kids that would have left at 15 didn't leave, were pissed off and just beat me up more often. So it didn't seem a good thing to anyone, but it turned out that it was, which is good. We can do Mendelian randomization, negative control analyses, outcomes. I'm not going to go through this because I'm going to produce Mendelian randomization enough, but a germline genetic variant which influences cholesterol level or alcohol drinking or smoking, the one thing you can be sure of is that can't influence your age. Genetics can't influence your age, except by influencing your survival, maybe, and it can't influence your sex. So in many randomization analyses, we often do outcomes with age, sex, we do hair color, and just other things which are just implausible to be influenced. And so I'll move on from this. Suffice it to say, you get in some MR analyses, you get apparent effects on age and sex, and so that just makes you just not trust the analyses on cardiovascular disease or cancer or whatever they're looking at when you're getting these differences with negative controls. But that's just I like negative controls. I'll skip this bit, the last bit I'll skip, which is you can also use another example of using genetics to understand confounding. Have you heard of target trial approaches? It's a sort of statistical analysis approach which tries to mimic a trial. So you sort of select the people who would get into a trial. You'd exclude people from your observational data if they would have been excluded from the trial, for example. I'm not enormously enthusiastic about it, so this is just a demonstration how you can get the wrong answer. Now, I talked about mechanism. One thing which is hard is thinking about ways of getting unbiased evidence on plausibility, biological plausibility, because of course there's just a huge literature, and the possibilities of sort of cherry picking the literature. You do your study, you find something, and then you go and look for something which supports it. And I remember but they provide obviously powerful evidence. But there's limits to that sort of conventional biological plausibility. I worked for many years on HIV transmission and school of hygiene. I opened a journal, and there was a paper on the cofactors in male to female sexual transmission of HIV. And this paper did some nice adjusted analyses and came up with the fact that all contraceptive use increases risk of future HIV infection. And the explanation was a direct effect on the genital mucosa, making it a less successful barrier to HIV, and an immunosuppressive action which would increase susceptibility to HIV. And so I read that and I thought, that sounds, they both sound plausible. And literally, the sort of next issue of a journal, the same for the week, there was another paper on the same issue, and it found the reverse, that oral contraceptive use appeared to protect against HIV infection. And they said, suggesting containing oral contraceptives stick in the cervical mucus, which might be expected to hamper the entry of HIV into the uterine cavity. And that sounds reasonable too. So just sort of having a system where you just go out and search the literature to find something that supports something biologically doesn't add value at all. So, which is why the talk has pre-registered triangulation. You have to have some form of specifying things before you include them. And one thing which is a sort of an area for research is sort of when you set your study up would be to actually elicit priors from people who aren't involved in your study, they're not epidemiologists, get people who actually know about cervical mucus, etc. And just pick a group and actually get trials from them about what they think has biological validity, and you can actually then indeed even use that with some sort of weighting system and a Bayesian analysis. But you have to do it in advance. So quantification is useful up to the point when it starts to harm inference. And so some things just don't actually add quantitative estimates to what you're doing, like some negative control studies won't do that, won't actually give you a quantified effect. estimate, but they do give you a notion of the plausibility or not of your outcomes. And I like thinking of triangulation as being like crossword puzzle, because it isn't in a sort of extensive triangulation of evidence. It isn't just things which intersect directly with what you're trying to estimate, which give you support. It's things which actually support some of those intersecting things. So what is strong is when those things agree. So this is the crossword. Imagine, and you've got you're asked for probability, and then you look at the thesaurus, and you've got involved, confused, puzzling, tortuous, involute, baffling. So that's the answer there. And then you don't know that. You obviously don't know which one it is. But then the first across is A and O, for instance. Anyone get any answer to the crossword A and O, for instance? Sorry? No. Could be blood group, or blood type, or blood group. Could be blood type. And then none of you will know this one. Oh no, sorry. Chester's girlfriend. Well, some of you must watch 1950s, 40s films. There's always a mole. That one's about that. I'd know that blood group and mole I could get it. So. And then, but none of you will know this one, which is Besom. Unless is anyone here from Newcastle in the UK? Besom is a broom. If you live there and you know someone who did do, then you'd be able to get that. And of course, when you get through, that reduces your solutions to convoluted, is confused or tortuous. You've only got two left. But the broom is, you believe that because it's supported by by the others. And then you get discharge of water, which is outflow. Yeah, and that means you think it's tortuous. So then you just check it with the churros and resistance. But the point is that the blood group, these things that provide support for something which is essential to your inference, those things are powerful. So one's got to think of sort of, sometimes you might, to get stronger evidence for one thing you're directly interested in, might be to get something which doesn't even directly intersect with it, but supports another plank of that. And I think I've covered Bradford Hill's viewpoint, so you'll have noticed that some of these things sort of overlap, like experiments. But like specificity is like negative is similar to negative controls, and consistency and plausibility I've talked about, etc. So these are, and there's many different approaches, but I think that the Bradford Hill viewpoints, he never scored them criteria, and I think they've been badly done to in a way, because I think they're a good informal way. I think it's important that you have a protocol which is developed and pre-registered. This is for the National Heart London Blood Institute, when they funded a lot of trials of dietary supplement interventions, and remarkably, seeing as all the large-scale trials never show any benefit. Well, none of their trials, there's hardly any of their trials that were massively beneficial, and then they made people have to publish the results, and then and whatnot. So without pre-registration and then having and saying what you were looking for, and not being able to change the goalposts, there's obviously quite a lot of goalposts going on. If you actually pre-register what you're going to do, then you can't then torture your data and just look for a nice low p-value for something you haven't specified. You can't hypothesize after the results are known or harking. So that's if you look at the notes and then you look at your results, sorry, and then you come up with the hypothesis after you've seen the results. You can't be influenced by what you want to believe in, because I think there's biases coming up in many forms, including things that one just believes in. And of course, open access data, if the data are accessible, you can't just torture the data till they confess, because someone else can get the data and can check it out. This promotion was BMJ 30 years ago, and the editor of the BMJ was quite keen. He took it to his editorial board that they were going to make people send in the data if they sent in papers. And then he asked for a vote, and he was the only person who voted for it. But this is now becoming commonplace, that you've got to at least say you'll make the data accessible. And you pre-register a protocol, and there's lots of places now, lots of websites where you can pre-register the protocol for your triangulation study you're doing. And I think absolutely key to this is that the consensus comes from what you say is acceptable evidence, rather than when you look at the evidence and then say it was acceptable, then say, oh, I don't like that bit of evidence. Once you've pre-registered it, so we're going to do this negative control, this cross-context comparison, and that's it. Then you've got to do them and report them. Potential limitations in you game the system, you pre-register after the results are known, but that's just literally fraudulent. So, although that can be the case, and those are the people I'd like to thank. That's Mentoring and Randomisation. If you want that, there's a great conference in Bristol. Oh yeah, and if you've got any people, someone you really don't like, then you can buy this book for Christmas, because that'll be. Thanks very much. Sorry, I went on for 58 minutes. Sorry, okay. Thank you. Get online. Everyone wants lunch. That's very sensible. Yeah. So with a negative control, you would think you're in a situation like with the vitamin E, for example. You're doing this vitamin E, you're doing 99% of the vitamin E study results. But what you find is papers just tend to report one outcome. They report cardiovascular disease as an outcome. But you know from looking at your data that, for example, the socioeconomic position, lots of health, various health behaviours associated with that, are likely to be sort of confounding factors. But you've adjusted for them, but you also know that measurement error means you can't fully adjust. And you also know that there's likely to be factors you haven't measured. So if rather than just reporting vitamin E and cardiovascular disease, you think of an outcome which vitamin E couldn't influence. And those outcomes, outcomes could be something. I mean, accidents and violence are often used because they're unlikely to be influenced by that. But you could, you think of the outcomes don't need to be death. You could think of any outcome that couldn't be influenced by cardiovascular disease is developing. But that's why you've got to think of that, and then that's why it's good to go and get discuss with others, people that are just new thinking. That's why the pre-registration, because the pre-registration is other people can look at it and comment on what you're doing can help. Now, some people then would go on to say, well, if we look at accidental violent death, and there's 35% reduction in coronary heart disease, and there's 45% reduction in accidental violent death, you'll think that's But while it was 35% reduction in cardiovascular disease and 25% reduction in accident and violent deaths, can you just then sort of can you just say, well, it's 10% benefit which we need? I mean that, but of course it's not quantified, so you would think that it would have precisely the same effect. It's just you would be looking at something that would that would reveal that there were other compounds, and that would make you think you should go out and do a cross-context comparison, or do a study of a different situation, some sort of trial, and try and find some way something which can actually influence vitamin E consumption. I mean, one thing I did some messing around with the numbers. I showed you that massive extent to which vitamin E supplementation went up amongst the members of health and amongst that group, and went up from like 10% to 60%. And it was supposed to reduce coronary heart disease by 35% in 4 years. You should have seen a substantial fall in mortality. I mean, so I didn't talk about etiological data. I mean, which includes time span data. I mean, one of the, when smoking went up, lung cancer and cardiovascular disease went up. And so there's things that people think are caused by smoking, like threefold effect of suicide. When smoking went up from, cigarette smoking went up from, literally zero around 1910 to 80 or 80% of now smoke. There should have been a massive suicide, which there wasn't. So but everyone, we all think ecological data are really weak, and but if you get something where the things just don't fit, then it really should make you doubt what's wrong.
So, from that perspective, this triangulation very different problems about.
Yeah, well, but systematic reviews would very often get get studies that are all done in the same context. So systematic reviews of observational studies just give you greater confidence intervals around the compounded effect, and the systematic reviews of randomized controlled trials are obviously different. Triangulation, for example, we want to systematically review the negative control studies and observation studies and different study designs, or please specify, as some systematic reviews do, please specify if you think this context where you would get different biases, or you might even expect different effects, then you would please specify that you're going to stratify by those characteristics. But on its own, systematic review is just this weighted average. So, yeah. I think they're all biased. Yeah, which is what I showed with beta carotene. We did a little systematic review. It was a long time ago, but they all pointed in the same direction. The interesting thing was that they stopped pointing in that direction because once the trials appeared, no one published any studies suggesting benefit because they knew what they had to do.
Kind of if you look triangulation was mostly the initial evidence and observation of it. During COVID times also again I don't think COVID some evidence, some observational solutions that suggested some small protective effects. But later on the trial evidence suggested that. So what kind of because evidence ultimately influences policy. So how do you see a balance between triangulation? How do you see this triangulation in times of public health emergencies? How do we balance the delay in the trial evidence and
I mean, I think in Norway, they did some very rapid reviews, and Norway actually was one country which investigated the cost of randomisation for school closures, but never actually did it. I think you have to engage in real time with the policymakers. So I think that with the pre-registered protocols, the thing is you get the policymakers to say what they would find convincing, and as I say, you get consensus on what's been listened, rather than being able to look after the fact. But if you know if there's no evidence to put together, then I think what we can do is be generally rather skeptical. But I mean the examples where the Mendelian randomisation showed that strongly suggested that IL-6 receptor blockade would reduce mortality in COVID, which it did. So that's what the MR studies were done before the trials. And in fact, the target trial analysis suggested the same. So. Yeah. Yeah, I mean that would definitely be a situation where getting data from different contexts would be very valuable. I mean, so you're talking about data from India, but have people have presumably looked elsewhere where lockdowns are less effective, with less people, less effective, etc. So I mean, you need to think of how what one could get, and also look for you'd be able to think of things which couldn't plausibly go down because of lockdown. But you have to know that you have to be content expert in the area that you're trying to explore. Any other questions? Thank you. Thank you for the presentation. Assessment professor. So I'm very thankful for you taking this class, and since I also teach them basics in epidemiology, I think your lecture has also given you some new insights into explaining the importance of triangulation and in data. And I'm also thankful to the organizers, to Ranjan and Ma'am, for helping conduct this session. And I'm sure that all students have immensely benefited from your insights, and they will be able to utilize these insights in their future careers, and they will keep in mind the importance of triangulation when trying to assess evidence. So thank you once again.